when people elected to present their submissions orally, they were given some good instructions about how that process would flow. And so your allotted time does include questions. And so I'm just reminding people again that councillors sometimes do have some questions, so if you can bear that in mind when you're making your presentation. Secondly, councillors have got electronic equipment that they look at the submissions on. So if you see us looking at devices and fiddling around with things, it's actually because we're looking at the pages on our iPads or laptops, or some may even be using their iPhones to read these documents, rather than sitting here with big ring binders full of the paper. And thirdly, it's very, very important that the submitters be given quiet time to do their submissions, so that councillors can hear and listen to what they've got to say. So please make sure that if you do have cell phones or anything else, make sure they're off so they don't interrupt what's going on up the front here. And if you can not talk to your neighbours and stuff like that, because what actually we found is it starts vibrating back up here, and it is putting some of the submitters off when they're doing their presentations. So just a few housekeeping rules to keep us going. But otherwise, I think it's working really well, and it's a really good environment. So thank you very much for everyone that's given us that. All right, we're going to kick off now, and we have Dr. Alan Isaac, who's here to speak to us, and he's got a 10-minute allocation, including questions. Only needing 5, that's great. Hi, Alan, welcome along.
Thank you. Thank you, Mayor. You will have received, councillors, my page submission previously. Essentially, I'm an orthodontist, specialist orthodontist, and have been in practice in Hamilton for 35 years. Thanks for the opportunity to express my views on this matter. At this time, I only wish to expand a little on the points mentioned in my submission. The Ministry of Health representatives yesterday have given and presented the factual evidence regarding the efficacy and safety of water fluoridation. There's much literature on water fluoridation, but I would counsel that to judge the value of articles and publications, it's important to know their source. Peer-reviewed articles and journals are the only reliable information. And in scientific research, less relevance is placed or given to isolated case histories and studies, and most to randomly controlled trials. For any area of dental research, if you don't have this reference, I would refer you to the Cochrane Library or the Cochrane Collaboration, which has systematically reviewed and ranked all published papers on most topics. Of course, not all science can be trialled. For example, that wonderful anti-gravitational device called a parachute was invented by Louis-Sébastien Lenormand in France in the late 18th century and is universally accepted, but it would be unethical to have a control group compare whether it works or not. But, you know, water with 1 part per million fluoride occurs naturally in many parts of the world, and public water supplies have been fluoridated in New Zealand for over 50 years. There is a wealth of evidence to support its effectiveness and safety. Where also is the evidence to back up claims of dire health problems caused by water fluoridation? Some opponents want water fluoridation stopped, but want to choose fluoridated toothpaste for their proven benefit. That's inconsistent with claims about fluoride products being poisons. In fact, most households have aspirin and paracetamol in their medicine cupboards, and both of these common products can cause death if a small overdose is taken. I greatly sympathise with Council's position. It's extremely frustrating that there is inadequate legislation and regulation from central government. Organised opponents of fluoridation are thus able to use attrition and try and wear down councils. It may be debatable legally, but it certainly should be possible mentally to weight the value of local and reputable evidence compared to the out-of-town interested parties. I liken this barrage of submissions, particularly by emails, by this group as strongly akin to text bullying. And I strongly urge the Council to resist the temptation to give in to this, hoping it will all then go away. because I can assure you that we in the health professions will also not go away from a cause we believe in. It's interesting in this morning's Waikato Times to compare what happened in that situation in the Tampa city in the United States, where it was removed and a year later, after a lot of discussion and consultation, reinstated. Tooth decay and dental health is multifactorial in origin. Water fluoridation is the most effective preventative measure in that battle. It also benefits everyone, young and old, regardless of their social status. The Waikato District Health Board recently advised that over 1,000 children a year require a general anaesthetic in order to treat their bad tooth decay, unquote. From the Tauranga experience, there is no doubt that number will increase if water fluoridation is stopped. I worry that dental services and health budgets will simply not cope with this, and children and families will suffer. Can I therefore strongly advocate for children here? They have no vote, and so it's essential that adults make responsible decisions on their behalf. In conclusion, to plagiarise the phrase, "I'm local and I care," sums up my position. Thanks for your attention.
Thank you very much, Helen. So, Dave, I was going to call you Dr. McPherson there.
Oh no, that's Dr. Cave, remember?
Oh.
Sorry, do you want to stay there for questions?
Yes, that's just a summary of
I don't really want the paper, but...
Right, what's your question, Dave?
You're talking about or criticising the anti-fluoride campaigners for describing it as a poison and saying I think you're saying put it in context, more my words, not yours. It's been acknowledged in a lot of studies recently, according to evidence we've seen, that fluoride, the effectiveness of fluoride is topical on teeth, not systemic, Well,
it is both, but the major
it's
effect...
both, is it?
It is both, of course.
What's the effect then that's not topical?
Anatomical change in the structure of teeth was proven 50 years ago by natural differences, but they're subtle in the formation of teeth, and histological studies show that during tooth genesis or formation, that fluoride can be built into the teeth. But the major effect of water fluoridation is topical on the surface, that's correct. The difference, fluoride is a very strong ion, and what it does is it transfers or displaces the hydroxyl ion, which is OH minus if you like, from the crystal, the apatite crystal of the surface of enamel. Now that's a very weak ion. Fluoride is a very strong ion, so it binds to the apatite crystal and makes it much stronger, and that's what it provides. But what folk don't understand is the surface of a tooth is not static. The environment is changing all the time. That's why people who have loss of saliva after radiotherapy and medications have problems, because there isn't a constant transfer of ions. And if you strengthen that, then you make the tooth stronger. If you take that away, then the tooth becomes weaker.
Talking about the topical nature of thing of fluoride, as you just have been, are there other ways that are as effective in providing the topical support that you're describing fluoride
Certainly.
gives?
I mean, throughout the world, whenever fluoride toothpastes have been introduced, you'll automatically get a 30% difference between non and fluoridated areas. The trouble is that not everyone has toothbrushes, not everyone has fluoride toothpaste, let alone any toothpaste, even in New Zealand and locally here in the Waikato. So the measure of using water fluoridation is universal. It benefits everybody, and particularly children who don't have the opportunity to choose. So it covers all social.
And are there any negative effects of fluoride in water anatomically?
Not in proven scientific, evidence-based literature.
Thanks.
Okay, I've got Councillor Henry and Councillor Forsyth.
Yes, are you aware of Napier and Hastings, both of a similar size, one
Yes.
fluoride and one not?
Yes.
Are you aware of the findings?
Yes. The thing was, initially, when the initially that was planned as a comparative Twin City study. The difficulty was, following the earthquake and the change in Napier at that time, in the 30s, there is a difference because they surmise that it's to do with the fact that the area which raised out of the sea by several metres was market gardening areas. And there are natural fluorides and other elements present in seawater, and these were being used locally. So when they came to do a control of Napier compared with Hastings, thinking they would be identical, they were not. And it was simply the fact that there had been a change in the environment, which changed the natural baseline was different between the two. So they had to do a completely different study than what was originally intended.
In Europe, particularly in some of the very poorer countries who don't fluoride, the incidence of caries has gone down. What do you attribute that to?
I think the European situation is very complicated because it's not one situation. Every country and within countries, because many countries have had war situations in recent times, there is a huge difference in different countries and within the same area. The removal of fluoridated, or deliberately topping up fluoride to an optimum level in Europe is really related to political decisions, which are also due to things like removing mercury, removing elements, everything else, which governments have done trying to have clean environment, as they call it. So they've removed everything. If I can digress for a moment on that, for instance, they removed mercury, had to be reduced from everything. It wasn't allowed in products, minimum amounts. And they hadn't actually thought through what it would do for dentistry, because in doing so, now in many countries in Europe, you can't use amalgam restorations because they contain mercury. The difficulty is the alternatives, the tooth-coloured restorations are not proven, not well proven, and in fact they're petroleum byproducts. We don't know the method entirely of where they are of removing them.
Thanks, Alan, very much for that, and thank you very much for your presentation.
Thank you.
Very good, and thank you for the handout. All right, we have our next speaker, and that is Carolyn McKenzie.
Good morning, councillors, and good morning, Your Worship. Thank you for having us along. I'm here as a chairperson of Patients' Rights Advocacy, Waikato, and therefore much of my time is taken up with trying to resolve some rather appalling situations for desperate people when things go very wrong. So you will forgive me some cynicism when it comes to the marvels and safety of modern science and its medical counterpart. I think as a nation we have a few historical acts of recklessness for which those in authority accepted little or no accountability. I'm thinking of the aerial spraying of 20 million litres of 2,4,5-T, which after the USA banned it in 1965, we continued until 1987, along with its manufacture, which has poisoned so many and deformed their offspring in the little township of Paratutu. The denial and sidestepping by the Ministry of Health was worthy of an Academy Award. I'm thinking also of the encouragement given to farmers to use dieldrin without reservation until its bioaccumulative effects were realised, and then the government's refusal to help remediate the soil for the many who faced ruin. I recall the first time I filled my car with unleaded petrol. It cost me $5 to fill the tank of my baby blue Buick convertible. It was in Sausalito, in San Francisco, and the year was 1968. This was something you couldn't do for another 30 years. But then again, your Royal Society, and significantly the MOH, felt that lead in petrol wasn't harmful. So we are currently the only nation still using 1080, except for 20K, which Australia's been taking annually. And we dump 98% of it aerially, which is about as sensible as dosing water supplies with industrial waste when you think about it. Additionally, we aerially drop, I hope I've got this correct, brifidicum, and we widely use methyl bromide, which is also banned throughout the world. The critical factor is not whether the gorse has returned or that the government's losing trade through beef being rejected because of the levels of endosulfan in it. It's about the health of our people, which is very poor. We had 368 stillbirths last year in New Zealand. Why? We have some of the highest cancer rates in the world. Why? Our levels of osteoporosis in women, and now increasingly in men, are at epidemic level. Why? New Zealand boards around the country can keep saying there is no evidence of this or that there is evidence of very poor health. And with 540 suicides last year, there is clear evidence of unhappiness too. I know there is such a high toxic exposure for our people on a daily basis that it seems taking a precautionary approach with adding anything more is probably the best way forward. I must say I was very impressed recently with the UK government select committee hearings on the safety of smart meters. They heard all the data from both sides and took the precautionary approach at the end and decided to delay rolling them out for another year, just to be sure. It's a shame that we couldn't do that. So anyway, further to this, I'd like to introduce you to one of my personal heroes, a man called Ralph Nader. Many of you will have heard of him.
Many years ago, when I looked into the fluoridation issue, I asked the question, who should decide? This obviously deals with a chemical application to the public drinking water designed ostensibly to reduce cavities, which is a non-contagious ailment. The question should be, who decides? And in more and more communities, it's a administrative or regulatory agency that is making the decision without adequate public input. I think that's wrong. If you're going to put a chemical like a fluoride in the public drinking water without even coming to the conclusion about the total fluoride intake in the community from other sources of fluoride before you make the decision, that's not up to anybody but the people by referendum preceded by an informed debate. That is not happening in most communities now in America. My hometown in Connecticut was fluoridated by a precipitous decision of a state agency with no input from the residents of that community. When a state agency rules it, it overrides the local municipal agencies. It overrides a local referendum, and in effect says to the people that when you open your faucet, there's going to be something in that drinking water added that you did not give consent to. Now, it's one thing if it's an epidemic disease. This is not an epidemic disease. What's happened is the Public Health Service and the U.S. government refuses to even have any kind of update analysis. The matter was closed scientifically several decades ago by the U.S. government, which is the principal promoter of fluoridated drinking water. And that's not a scientific attitude, in my judgment. One of the definitions of science is it has to keep open options for revision. And the idea that there's no debating critics of fluoridated water, there's no reevaluation in a deliberate matter, it's a taboo, and it's an unfortunate taboo. There's a very strong core that's been built up that looks at fluoridated drinking water as a closed matter. It's not the first time that's happened in public health, but once that happens, you get a vested interest. You get a vested interest of the scientists who bought into it. You get a vested interest of the bureaucrats who don't want to be exposed for having made the wrong decision. You get a vested interest for the industry that sells the fluoride. And all that combines with a juggernaut that makes the critics of fluoridation sometimes so desperate that they don't make sound claims. They exaggerate the alarms, and then they are tainted as being wackos. And so it's not a fair evaluation in a cool, thoughtful manner of all the pros and cons, but more important, of why the decision to fluoridate drinking water in community after community is taken away from public referendum and the decision by the people.
Thank you. I'm happy to take questions from here in.
Questions?
No?
No, we have no questions, but thank you. Oh, right, Councillor.
Else will? Your man up there says the community should have a referendum. Do you think Hamilton should have had a referendum?
Well, Hamilton's referendum was rather a sad indictment against the political ignorance of most of the community. Very few people voted in that. I think it was only 23%, wasn't it? But if you wanted a referendum, by all means, as long as both parties have equal amount of money to spend on promoting their particular point. I do have here 3 pages of names of doctors, naturopaths, osteopaths, and other Wellington professionals, and some outside of the Wellington region, which will be copied off and given to you. It's quite an impressive list, and these are all people who also support the idea. Local Government Act also does have as one of its principles that no local government, no council, should be adopting a one-size-fits-all approach in any of its policies. So if you want a way to move away from this awful decision, it is in the Local Government Act.
All right. Thank you very much
you.
for your presentation. Okay, the next presenter is Glenda Smith. Hi Glenda, off you go.
Good morning, Your Worship, councillors. I am Glenda Smith. I am a Hamilton resident, and I strongly support continuation of fluoridation of Hamilton's water supply. Until my teens, I grew up in rural Otago, where the family either used tank water or non-fluoridated supplies. Both my parents had false teeth, and myself and 4 siblings, we all had poor oral dental health. I have recollections from primary school of having regular episodes of sitting in the school dental clinic chair, not realising the seriousness of my decaying teeth, just knowing that it was a painful experience and feeling guilty because of their poor state. Today I continue to have dental decay at a great financial cost, and it's a battle to keep my own teeth. I've always recognised the benefits of water fluoridation, and I'm pleased that my daughter has been raised in a city that has supported it. She's 21 and currently has no cavities. In 2006, when the council carried out a community referendum, I undertook research prior to deciding whether to continue with my support. I wanted to know if the statements made against were valid or sufficient to sway me to change my mind. I found the facts overwhelmingly supported it as, yes, I'm going to say it, safe and effective. I found the water fluoridation supported by international, national and local health organisations. There had been extensive scientific study to support its safety, confirming fluoride in drinking water at the correct monitored levels can do a lot of good without doing any harm. I was therefore one of the 70% of the Hamilton residents who voted in support of the continuation of water fluoridation. I understand it is the role of council to carry out leadership, including advocacy and facilitation on behalf of the community, and therefore they need to address the ongoing request for cessation. However, I also understand that it's a small group of individuals that frequently and strongly voice their opinions, contrasting with the silent majority that makes up most of the base, of the community base, but rarely gives their opinions. I've chosen to speak at this tribunal hearing to represent that silent majority. I know it is the majority of Hamilton that want their water supply to continue to be fluoridated because they have told you so. That was reflected in 2006 with the referendum and the supporting telephone surveys. And again in 2013, your resident survey and your citizen panel survey has told you that the majority support it. I'm confidently speaking up because I have again reviewed the literature and found there's been no significant evidence to cause people to change their minds. From my research, a review of studies regarding fluoridation was undertaken by the National Fluoridation Information Service and published in 2011. They found a total of 25 international papers were reviewed, and an NFIS reported that the water fluoridation reduces the prevalence of tooth decay in children and adults, and there is no evidence that water fluoridation at the recommended levels is linked to bone fractures or cancers. And there is insufficient evidence to suggest a link between fluoride and any other adverse health effects. Based on the opinions of those who would like to stop water fluoridation, by now I would have developed at least one of these conditions: arthritis, thyroid problems, some type of cancer, dementia, basically the A to Z of diseases. Okay. My daughter would have developed fluorosis, have a low IQ after drinking water for decades. But I'm pleased to announce that neither of us have any of these problems. During my research, I also learned that the Public Health Commission reviews of 15 New Zealand water fluoridation studies found that 13 of them reported significant benefits from fluoridation. Overall, it's estimated that water fluoridation prevents between 58,000 and 267,000 decayed, missing or full teeth in New Zealand every year. I don't think that these findings are insignificant. I'd like to remind Council that a public health measure, water fluoridation has been described as the most cost-effective preventive method of tooth decay. It's important to remember that it benefits everyone, as fluoridated water acts irrespectively of an individual's behaviour, their ethnic group or their socio-economic status. This means that water fluoridation benefits everyone who has their own teeth, from older children, the elderly, and people especially those most at risk of tooth decay. There are many people who, for many reasons, struggle to carry out regular dental care, such as dental checkups for their children. Children living in poverty, it's not always a choice to have toothpaste or even a toothbrush. These people benefit by having fluoride protection in their drinking water. Children from low socioeconomic status areas, such as Māori and Pacifica, peoples have also shown to experience poorer oral health outcomes compared to other population groups, and they benefit the most. Local dentists have spoken of the facts of fluoridated water supplies at the recommended levels in Hamilton City is a key contributor to reducing decay inequalities in oral health in Hamilton. Everyone gets the benefit, just not those who can afford it. One of the issues raised by those who would like to see you stop water fluoridation is human rights. But we have a whole range of public health measures that involve some minor restrictions of personal rights or freedoms for the greater good. Examples that councils are already involved in are the fencing of swimming pools, food hygiene legislation, treatment of drinking water, and the enforcing of the building code. Limiting personal freedoms for the greater good is already justified where it results in reducing health inequalities and improved outcomes for vulnerable groups. Thank you. Another issue raised is the claim of mass medication. However, this must not influence Council's decision. As it stands in New Zealand, adding fluoride to drinking water at the level Hamilton does fails to meet the criteria to be deemed medicine. If there is any doubt as to whether it is or not, let the courts decide that. Community water fluoridation is about health and well-being and not dollars. As a Hamilton City ratepayer, I believe that $40,000 a year to add fluoride to our water supply is definitely a worthwhile investment for the Hamilton community due to the improvement of oral health and prevent dental decays. Do not be swayed by the number of submissions you've received to stop. While the numbers are high, it is inflated submissions from those who are not Hamilton residents, people who do not use our water supply, along with those who just signed a piece of paper for the sake of it. It raises concerns that the number of submissions received opposing is not truly a reflection of the stance of Hamilton people. I refer you back to the surveys I referred to earlier. I, like you, am not a doctor or a scientist, and just as you have to rely on the advice of experts, consultants, advisors, and reliable research papers. I would like to point out that the Ministry of Health and the DHB medical staff do have responsibility to reduce inequalities and improve the health of the public. If there was any credible evidence that it does cause health effects that being claimed, they would be duty-bound to review their practice and alter their advice. I've been guided by the facts from the sources. The sources of evidence is overwhelming. The Council should listen to the professionals who support fluoridation of water supplies and not be swayed by those few who oppose. I believe our community has long valued the greater good over selfish interests, and it takes only a vote from each of you to reaffirm these values and invest in the city's future.
Councillor Forsyth, question?
Thank you. I just have a wee question. You did allude to it. We had an earlier submitter who was pro-fluoride, and she posed a question, and I'll follow it up. Do you think Hamilton City Council should add vitamin C? That's her words. So I'm going to add selenium, aspirin, iodine to our water supply for the greater good.
Certainly not.
Why not?
So that aspirin that is deemed, anything that is deemed a medicine should not be added in quantities. I just think they should be administered by health professionals.
What about selenium, vitamin C and iodine, for example?
I haven't researched any of those vitamins to know what effect or whether it should be.
No opinion about vitamin C?
No. I support vitamin C. I know the value it has, but as the viability or how it would affect adding to water, I have no idea.
Okay, thank you.
Okay, thanks very much, Glenda, for coming along. The next speaker is Jane Beck, and Jane is she's making a presentation on behalf of Fluoride Free, Thames, and then on behalf of herself, so she's going to do those together. Is there a movie or a video as part of this, Jacob? Just as a PowerPoint, okay. Yeah. Yes, yeah.
Your Worship the Mayor, councillors, ladies and gentlemen, thank you for this opportunity to speak at the Tribunal on fluoridation of the Hamilton water supply. My name is Jane Beck and I'm making this presentation on behalf of Fluoride Free Thames, a group formed to oppose the fluoridation of the Thames water supply and elsewhere, and also a presentation on behalf of myself as an individual. Whilst based outside the city, members of this group and myself wish to express our view because we do visit Hamilton for work, leisure and health reasons. And Hamilton and Thames are both in the Waikato Health District and both currently have fluoridated water supplies, and the outcome of this tribunal will impact on Thames. So I'm a retired medical practitioner. I previously worked in the UK, and these are my qualifications. Since you may be unfamiliar with them, I'll just go through them briefly. The BSc is a Bachelor of Medical Sciences in Immunology. The MBBSc is a basic medical degree, Bachelor of Medicine, Bachelor of Surgery. And the latter two are my higher qualifications gained through specialist training, examination and research dissertation, membership of the Royal College of General Practitioners, and member of the Faculty of Occupational Medicine, which is affiliated to the Royal College of Physicians. Of course, I'm a retired doctor, and so I don't pay my ongoing membership. But I do believe my background makes me qualified to comment from a health professional viewpoint on the fluoridation of the water supply as a public health measure. See if I can work this. So just to be clear, we, Fluoride Free Thames and myself, believe that councils should stop adding fluoride to the Hamilton drinking water supply. One of the reasons councils feel inclined to continue water fluoridation is because it's believed by some that it reduces the oral health disparity that exists between the at-risk groups, the Maori and low socioeconomic groups, rather than those who are more privileged, and we've heard a bit about this already today. And so I would like to look at this more closely, at this oral health disparity, and explore with you who it is that is at risk of tooth decay and therefore the oral health disparity, why these people are at risk, what the actual impact of water fluoridation is on reducing this oral health disparity, and how oral health disparity can be reduced without water fluoridation. So our New Zealand Oral Health Survey from 2009 clearly shows us that the Maori, Pacific and low socioeconomic groups are those that are most at risk of tooth decay. And the 2011 Ministry of Health statistics of the Year 8 children, that's the 12-year-old children, the latest statistics show us here that on average 54% of these children are actually free of tooth decay. But as we can see, the Maori are only 41% free and the Pacific Islanders 39% free of tooth decay. Because the next few slides talk about DMFT, I'm just going to remind you what that is, although I'm sure most of you do know what it is. It's a tooth decay measure. It's the number of decayed, missing or filled teeth, and the capital letters indicate that they're adult teeth in these 12-year-olds. And they'll have 28 adult teeth at this stage. Later on, they might get some wisdom teeth. So I'd like to actually look at the 46% of the Year 8 children who actually have some evidence of tooth decay. because these are the people that are at risk of tooth decay because they already have it. And as we can see, the DMFT on average in this group is 2.68 teeth. That means that 2.68 of their teeth are affected by tooth decay. In the fluoridated areas, it's slightly less at 2.55, and the non-fluoridated areas 2.84. The difference between these two areas is 0.29 of a tooth between the fluoridated and the non-fluoridated areas. And continuing to... Hello? Oh, am I... Have I done something? Oh, I pressed a button. We're back. It's amazingly easy to press a button. So looking at the DMFT for the ethnic groups, we can see that the Maori and Pacific do have more teeth affected, 3.12 for the Maori on average and 3.02 for the Pacific. So we'll have a look at these figures by fluoridation status. First of all, I'd like to talk about this large column on the right-hand side. This is the DMFT for the 1973 year. It's a World Health Organization. So in 1973, all children aged 12 had an average DMFT of 10.7. Today, or 2011, those that are at risk have these lower group just above 2. So I think one of the things we can be quite assured of is that if we do stop water fluoridation today, we will not return to the rates of the 60s and 70s. However, I digress. What is more important about this particular slide is that whilst we see the column on the right, the sort of greeny blue column, oh actually I think I've got a pointer, haven't I? These columns are the non-fluoridated areas, and the middle columns are the fluoridated areas. And we can see that they are slightly higher levels of teeth affected. But what's most important is the fact that 2.55 teeth are not affected by the water fluoridation. That's 2.55 of these teeth are not protected by water fluoridation. And these are the at-risk children. These are the at-risk tooth decay. This is the oral health disparity that's not being affected by water fluoridation. So in order to reduce oral health disparity, this is the tooth decay which needs to be addressed. By relying so heavily and perhaps complacently on water fluoridation to reduce tooth decay over the years, this oral health disparity has been allowed to persist in New Zealand. So we've looked at the group that are at risk, but why are they at risk? There's a recent study from Australia by Armfield et al., published this year, that was looking at sugary drink consumption, tooth decay and water fluoridation. And in fact, it's quite a useful study because it's taken into fact confounding factors. These are factors that also affect tooth decay on their own right, things such as toothbrushing and socio-economic status. So this has been particularly helpful since our New Zealand figures that I've been referring to are data that come from the school dental service, but which do not take into account these other factors. So it's not a complete picture. So perhaps this study can give us some clues as to why some of them are more at risk than others. And in this analysis, they have shown that these factors are independently associated with tooth decay. So there's more tooth decay in 11 to 16-year-olds who live in rural areas as opposed to those that live in the city. There's more tooth decay in those from low-income families under 40,000 Aussie dollars compared to over that. There's more tooth decay when the parents have less education, school level, rather than university education. And there's more tooth decay if the children brush their teeth once a day or less, rather than twice a day. And there's more tooth decay if they drink sugary drinks, one or more sugary drinks per day, rather than not at all. And this, interestingly, is where we find a double whammy. Because in fact, the children that are most likely to drink sugary drinks are those that live in rural areas, come from low-income households, whose parents are less educated and brush their teeth less often. So we have a whole cluster of factors associated together, all contributing to a greater chance of tooth decay. So does this apply to New Zealand children? Well, we have our New Zealand Oral Health Survey. 36.5% of children do not brush their teeth twice a day. And the Maori and the lower socioeconomic groups are less likely to brush their teeth twice a day than others. And Maori and Pacific children are less likely to access oral health services. This last factor is not something that was covered in the Armfield study, but is still very relevant. So what impact does water fluoridation have on this oral health disparity? Well, this is what we saw earlier, the difference of 0.29 teeth. But maybe it's even less than that because there are other factors which aren't taken into consideration with these data. Armfield shows that brushing teeth twice a day rather than once gives a saving of 0.27 teeth. Not drinking sugary drinks rather than drinking 3 gives a saving of 0.27 teeth. And having lived in a fluoridated area for greater than 50% of their life rather than less than 50% of their lives gives them a saving of 0.1 of a tooth. So back to this chart. I believe that the impact of water fluoridation is really very small on our oral health disparity. So how can it be reduced? Well, the at-risk New Zealand children do not brush their teeth twice a day. They probably consume 1 or more sugary drinks a day. They're less likely to access dental health services. And they have poor oral health in both fluoridated and non-fluoridated areas. So they would benefit from brushing their teeth twice a day. And they would benefit from drinking fewer or ideally no sugary drinks. And they would benefit from regular dental visits. So in order to bring this about, these children would benefit from school or preschool-based toothbrushing programs designed to create the habit of regular toothbrushing. They would benefit from health education in school and preschool, diet, in particular, reduced sugary drinks and other eating of beneficial foods. And they would benefit from enrolment in the free school and preschool-based dental services. We know that community oral health departments have over the years provided a free school dental service and given health education and toothbrushing advice through this. But preschoolers haven't benefited very much, and school-based toothbrushing programs have not been conducted widely. However, in the Waikato, it seems that around about 2008, or maybe possibly a bit later, they have an increased preventative focus. And there have actually been some preschool-based toothbrushing programs here in the Waikato. And there has been preschool-based health education. And there has been a campaign to encourage enrolment in the preschool in the free school dental service. And the impact of this step up in preventative oral health care has been quite noticeable in the 2011 oral health statistics for the Waikato. As we can see, up and down a little bit, an improvement here in 2008, but generally just a gradual increase, and then suddenly there's a bit of an exponential change here in 2011. This is a jump in 5-year-old children in the Waikato from 50% free of tooth decay in 2010 to 61% in 2011. That's quite a significant jump. However, I think this slide's also quite interesting because actually since 2006, we see that those in the non-fluoridated areas, that's this right-hand column, the sort of greeny blue, consistently from 2006 right to 2011, the 5-year-old children in the non-fluoridated areas have had more caries-free teeth than those in the fluoridated areas. And if we look at the Maori who are free of tooth decay by fluoridation status, we don't see so much before 2010, but actually in 2010 what we see is a levelling off. Ooh. I did fast forward. Whip. Okay, get the right button this time. A levelling off between the fluoridated and non-fluoridated areas. And then in 2011, this massive jump from 27% free of tooth decay up to 52% free of tooth decay in the non-fluoridated areas. Slightly less in the fluoridated areas, jumping from 27% to 32%. I presume this is the fruits of the step up in the preventative oral health strategy. And interestingly, this improvement in tooth decay rates in the non-fluoridated areas seems to be a Waikato phenomenon, rather than a New Zealand-wide one, and is suggestive of the effectiveness of the preventative oral health strategy currently happening here in the Waikato. And I applaud the community oral health team for their success in this venture. So in summary, oral health disparity exists despite water fluoridation. Oral health disparity can be reduced by toothbrushing, health education and dental care. And oral health disparity in the Waikato has already been impacted on by the community preventative oral health strategy. And in conclusion, water fluoridation is not an effective public health measure for reducing oral health disparity. There is no scientific research that has shown that water fluoridation is safe. And the potential risks of water fluoridation outweigh the minimal benefits. This smile belongs to a 13-year-old boy who has one filling, a DMFT of 1. He could easily have a DMFT of 3 and still have the same smile. And I ask the question, do we risk one extra filling or do we risk reduced IQ or other health problems? Well, if I was that at-risk child, I would rather risk the potential of one extra filling than risk my IQ potential or other health problems. And if I was that at-risk child, I would prefer to be given the skills and education to take responsibility for the care of my own teeth and have the chance to avoid those fillings that might have been coming my way than be given an uncontrolled amount of preventative medicine in my drinking water. This is the way for good oral health, and good general health for Maori and for all for life. So we, Fluoride Free Thames and myself, urge Council, for the sake of the community, to stop adding fluoride to the Hamilton drinking water supply. Thank you.
Thank you very much, Jane. No.
Dr. Beck, would it be a good idea, in your opinion, to put more resources into public oral health campaigns amongst young children, especially in the lower decile areas?
Yes, I think it would, and I think it would be something that would give us benefits in the future, because if you can instill habit, then that habit is going to carry on, and it will carry on to the children as well. I was speaking to a Maori girl that lives by me, and she has 2 fillings, apparently. She still has quite a nice smile. And I asked her how often she cleaned her teeth, and she said, oh, about every 3 days. And I thought, oh, goodness, I clean mine twice a day, because that's what we did. That's the habit that was created when I was young.
Thanks.
Questions? No? Debbie?
Just a question, would you recommend fluoride toothpaste for the education campaign or non-fluoride toothpaste?
I think that's a very debatable question. I personally don't use fluoride toothpaste.
Okay.
I think there may be some benefits, possibly for some children. I think we need to be a bit careful with the very youngsters.
Thank you.
Sorry, thank you. Just a quick question. So, could you tell me, what do you think is more effective? Is it brushing the teeth, or is it the topical application of? Well, no, you're not going to be able to.
Well,
answer that
actually,
one.
that is a question that's come to mind. I think the brushing of the teeth is important. I know we heard earlier about the plaque, not removing plaque was the new thing, but that isn't how I had previously heard it. I think removing the plaque, removing the bacteria, is the important factor. The fluoride is supposed to have an effect locally, topically. So if we are to have fluoride, at least with toothpaste you do have the choice, whereas with water fluoridation you don't have the choice.
Okay, thank you very much for your presentation. Okay, the next speaker is Nigel McCarter. Okay, Nigel, so you've got 10 minutes, including questions.
Good morning, Your Worship the Mayor, councillors. Thank you for the opportunity to speak. My name is Nigel McCarter. I'm an ex-scientist from Fisheries Research Division many years ago and from NIWA. After leaving NIWA in 1993, I started a company called Safety Management and Information Services to provide safety and chemical safety data and services to Crown Research Institutes and universities in New Zealand and overseas. And I'm semi-retired now. These days I edit science papers, particularly medical science papers from Tokyo, and environmental science papers from Japan, all over the British Medical Corporation Edans in Japan. I want to make 3 points, one on toxicity, one on the interpretation of science papers, which is how I got interested in the first place, and the third point on the verification of expertise. Even scientists frequently get toxicity wrong. It's very easy to misconstrue toxic data. Mercury, for example, is a lethal neurotoxin. Most people in this room will be carrying significant levels of mercury in their mouth with no ill effects whatsoever. In other formats, it's extremely poisonous. And there's a huge amount of misinformation about fluorine and many other toxins. Fluorine is very like chlorine. They're both halogens, one down on the periodic table. I don't think anyone in this room is going to suggest that we cease chlorinating public water supplies or our swimming pools because chlorine was used as a toxic gas in the First World War. Toxicity is, any chemical can be toxic. It depends upon the circumstance, it depends on the dose, it depends on the time, it even depends on the species to which that chemical is applied. And therefore, the interpretation of science papers on toxicity has to be made very carefully indeed. It's frequently very difficult. It's specialised, it's complicated, and unfortunately often deliberately misconstrued or misrepresented, particularly on the internet. For example, on the fluoride-free Hamilton website, there is a claim that a Harvard study finds that fluoride lowers IQ, published in Federal Government Journal, implying that fluoride in drinking water poisons children. Well, this is just misleading or just plain ignorant. It's not true. First of all, number one, this is not a federal government journal. This is the PubMed database, which is funded by the federal government, but doesn't actually warrant veracity or truth of the information therein. The actual paper, when you download it and have a look at it, is a metadata analysis written by 4 scientists, one of whom comes from, Anna Choi comes from Harvard Public Health, the other 2 come from Shenyang University, and 1 comes from Denmark. So a better description of this paper would be Shenyang University scientists find that, but that wouldn't be nearly as impressive as Harvard. It's a metadata analysis, which is not an original study. It is simply a collation of all the information that you can find on the PubMed database. I edited a paper 2 weeks ago which had 1,500 citations. This one has 37. And finally, when you actually dig really down into it, it's citing one paper by Ding et al., which is a study of children from an area of Inner Mongolia, which is known for endemic fluorosis. So the statement on the website that Harvard study finds that fluoride lowers IQ is either deliberately misleading or wrong. The research was not from Harvard, it's not federally funded, and it does not show that fluoride has any detrimental effect on IQ. Similarly, there are a succession of claims on the websites of adverse health effects that look impressive until you actually look at the papers and you download them. This can get quite expensive. And you realize the studies are from China, from India, from Bangladesh, from England, Inner Mongolia, Nigeria, one from the Rift Valley, and so on and so forth. Children in third world countries frequently, and particularly from areas of endemic fluorosis, who have to drink water with high mineral levels, are very frequently adverse affected. Whether this is because of arsenic, fluoride, or maternal nutrition is entirely open to debate. There's simply not a case to answer that fluoride universally lowers children's IQ. It's not sustainable. And what is quite clear is that most of that data is not relevant to Hamilton City Council. There's another problem on the websites of misquotation, but I haven't got time to do that at the moment. I didn't even start my timer. But it does lead to the last point I want to make, which is the verification of expertise. I think society has a right to expect that people presenting themselves as experts actually do have some expertise in the subject that they're talking on. I think we have a right to accept, for example, that engineers who are sent down to Christchurch to certify buildings should be a certified engineer. And similarly, if we are listening to someone presenting themselves as an expert in fluoridization or public health, they should have some expertise in that area. Then it's open to debate. You can measure this fairly easily because most public science information is freely available via things like PubMed database or even Google Scholar. And to give you a comparison, New Zealand scientists are expected to publish 2 peer-reviewed papers per year. 2 per year. If you're a scientist in a CRI or a university, that is your target. Not many of us actually reach it, I have to say, certainly not me. So over a career, over the 30 years, a scientist would produce 30 or so, anything from 70 to 200 papers on their particular topic of expertise. That is what marks the expert, and you wouldn't be calling them as an expert witness if they didn't have that track record. Now, I don't mean to indulge in personality,
tax, but the internet campaign keeps citing experts, and when you dig into their background, I can't find any evidence of expertise. For example, Dr. Paul Connett, who I gather is speaking by Skype here, is, I'm sure, a very nice gentleman, but he is not an expert on, in my view, on fluoride. He is an ex-professor, an ex-teacher from a small New York university. He's not from New York State, he's from St. Lawrence University, and he's retired from there. That was 2,500 students, rather smaller than Wintec. And I can only find 4 papers by Dr. Connett. 4 papers, 2 on chromate toxicity in 1983 and 1987, and where was the other one? One on TCD in milk in about 2004, and 2004 as a junior author in a review published by the Journal of Biomedicine, which sounds very grand, Journal of Occupational and Environmental Health, which actually turns out to be published by the University of South Bohemia, which is somewhere south of Prague, but it's not a cutting-edge place. It's one of 1980 co-authors has published 70 papers since then. And the point is this: if I found a series of articles by anyone in the Lancet or the American Medical Journal or the Centre of Disease Control which cited a particular problem, I would sit up and take notice and jump ship just like that. I can't find them. On the contrary, I find the Centre for Disease Control, Scientific American, British Medical Association all support fluoridization at low levels. With all respect, I do agree that brushing in health education is a very critical part. But I don't think, to take those points together, that withdrawing fluoride from the water supply based on iffy data from Bangladesh and Nigeria, and provided by self-appointed experts with no track record, is either sensible. I think it would be foolish, negligent, and irresponsible. Thank you. Councillor Forsyth.
Just one question. I'm interested to know, to hear your comments about the information that's just been presented to us by Jane Beck, Dr. Jane Beck. Did you hear that?
Yes, I did. Yes, I did, and I thought it was very interesting. I agree with a very significant part of that, in that I think campaigns for early health education would be critically important, but I do not agree that fluoridization has an adverse effect on children's IQ. I can't find any evidence for it at all.
Okay, but you agreed with the findings and the non-fluoridated...
I would have to look at those papers
Yep,
before
okay.
because that's
Thank
fine.
you. Thanks.
One of the things that I'm sure Dr. Begg and I would both advocate is that you read the original papers.
The facts,
And I would
yeah.
look up Armfield. I haven't found Armfield. I will certainly try.
Thank you.
All right, thank you very much. Oh, sorry, Roger.
Sorry, and I'm interested in your response there, because if you found that to be correct, would that change your mind?
Possibly.
Thank you.
One of the critical things about science is that you do have to change your mind from time to time. But I certainly find no evidence that CDC cites fluoridization as being one of the top 10 public health initiatives of the United States in for the 19th century. One of the top 10.
Could you get back to me if you do read it? I'd be really interested.
Yes,
Cause, thank you.
All right, thank you very much for coming along.
Thank you.
Right, the next speaker is Libby Boyd. So Libby, you've got 10 minutes including questions. Okay.
Okay, thank you. Thank you, Mayor and councillors, and thank you for this opportunity to speak. I've been informed that it's not a good idea to be emotional, so I'll do my best because I'm very emotional. However, I think that it's really important to have emotion because that's what moves us to do things and to not accept things. And I will try to be not emotional in this presentation, but however, I'm very emotive in what I believe to be true and what I read and what I listen to. And it's a part of discrimination. I'd also like to say here my credentials, besides being an artist with a degree. My credentials are that I'm a mother and a grandmother, and I'm 63, and I'm mature, and I'm old enough, and I've been through some stuff in my life, and I've been through some small cons, and I can recognise when there's a con, and I actually think that fluoride and the teeth is a con, and it's a cover for what's actually going on in the rest of the body. My submission of, you've already got a big fat book like this with 2 toxicological reports in them. You've got the index of pharmaceuticals with fluorines in them. There are 381 fluoride pharmaceuticals. Besides all the foods that we have, I don't really think we need it in the water. Our water is our last bastion for growing our own vegetables without fluoride accumulating in our bodies, in the vegetables themselves. A lot of vegetables like cabbages and broccoli and Brussels sprouts and grapes and berries, they use cryolite. It's supposed to be one of the natural fluorides, but it's actually a double compound. It's fluoride, aluminium and sodium. And I have in my submission, which you'll receive them over there, a picture of a cryolite worker and what has done to his spine. It's just one to start off with. Anyway, just to get through, I object to fluoridation in any water supply. I object to fluoridation in anything. I don't like it in food, medical drugs, cosmetics, skin products, cleaning, laundry, anything, you name it. We all have a right to have pure water, and that doesn't mean it's got fluoride in it. If it's got fluoride in it, it's not water anymore. Something else, and we're just the dumping ground for poison. Forcing toxic waste into us, whether one individual or 4 million individuals collectively, is unlawful and illegal. It is against all the laws. The Nuremberg law was the one that it was after the Second World War and the Nuremberg trials that they decided they changed all the laws, and that was the basis of everything. And it's in my first big fat submission, which you've got electronically. Also, in this one, I've got the Universal Declaration of Human Rights. And the Te Ture Whenua Māori Land Act says that nothing should be repugnant. And actually, one of the things that is the most repugnant of all is putting fluoride into water. It's a toxic waste. It comes out of chimneys. Then there is the principle of precaution, which came from the Rio Declaration in, I think it was 2000, year 2000, which is about environment and development of environment. The duty of care that also comes within that same group. And the precaution of care means if there's any doubt or uncertainty, and there seems to be a lot of doubt and uncertainty, and there ought to be, thank goodness there is, that fluoride adulteration, poisoning must not be done. The duty of care is another, it's like a promise, an oath. I don't know, but I think that councillors have a duty of care. A fiduciary duty also, a duty of trust. We entrust you to do good things for us. We don't give you, well, I don't give you my yes to putting fluoride in the water. Honouring us, you should honour us like you honour your own children. We should all honour each other and your children's children. The human rights, even in the human rights, we're not supposed to have medication or drugging or poisoning with any highly toxic waste. We're not supposed to be medicated en masse. And you've also got that in the fluoridation of violation of, in the big one, violation of medical ethics and human rights. The Roman law was, if it's not good for one, it's not good for all. Fluoride was used in World War II in the Nazi concentration camps to subdue and make the persons apathetic and docile. The drug was for mind control, and in this there are several articles about that, because that's, I think it's about there's a lot of statistics you've already heard about what it does, and I can list them here as well, but I'll leave that aside for the time being. You know it's poisonous, I think, and it affects the brain and it affects the thyroid, and there's another thyroid article in this submission as well. I'd like to read something that I put on the submission, which you've already got the first time, but there's another little response at the bottom. The October the 1st, 1944, an issue of the Journal of American Dental Association warned that we do know the use of drinking water containing as little as 1.2 parts per million of fluorine will cause such developmental disturbances in bones
as osteosclerosis, spondylosis and osteopetrosis, as well as goiter, and we cannot afford to run the risk of producing such serious systemic disturbances in applying what is at present a doubtful procedure intended to prevent development of dental disfigurements among children. Because of our anxiety to find some therapeutical procedure that will promote mass prevention of caries, the seeming potentialities of fluoride appear speculatively attractive. But in the light of our present knowledge or lack of knowledge of chemistry on the subject, the potentialities for harm far outweigh those for good. Now, 3 months and 3 weeks later, the City Commission of Grand Rapids approved a motion to fluoridate, and on January the 25th, 1945, despite the warning issued 3 months earlier by the American Dental Association, fluoride was added to the drinking water of Grand Rapids, Michigan, the first city in the United States to fluoridate its drinking water. Now, they had no chance to do any scholarship or study or research, but they knew a lot of history behind it. I've also got some history in this, and it's called the fluoride conspiracy. Don't be frightened by the word conspiracy, because it just means a secret plan. And usually those people have got something over each other in the first place. I've also got a section from the I think it's the DHB. This is just about births in New Zealand, and I've got the births in New Zealand and the number of births of the Waikato with disabilities, and they list them all as congenital anomalies. Now, I don't actually believe all of those are congenital anomalies, because I also know that when chromosomes join together, the male and female chromosomes join together, they all line up, and in the first cell division they flick away to divide, and they can break. Now, I know that can be tripped by alcohol, and I'm sure it can be tripped by chemicals. I'm sure, we've got pesticides and insecticides and herbicides and fungicides and mothicides and, everything you can name it. Why on earth would we think we can drink it? The Maori teeth were supposed to be the best in the world, written by Weston Price. He wrote that. And you've also got that in the original book. It's damaging to cattle and livestock. It's in a lot of foods. It's in a lot of pharmacy. I think I might leave it at there, because, you can tell I'm nervous. Everyone's nervous, I suppose.
Okay.
Anyway, I think you should not vote for fluoride. I think it would be putting yourselves at risk, and you might put yourselves at risk of a private personal suit if you actually do that. You're going against the Te Ture Whenua Māori Land Act, and, October's coming up and February's coming up, and we don't know when things are going to change, but they will change. And so we need to be doing the right thing, and I think, I'm trying to do the right thing.
Just see, Libby, if there's any questions for
Yeah.
you.
Libby, thank you. Are you comfortable with the level of naturally occurring fluoride in a water supply?
No, I'm not. I understand. One of the things about New Zealand is we're a volcanic area, and when you start reading all of this stuff, one of the things that is bad is volcanic areas. They are likely to have more fluoride, more sort of natural fluoride. But natural fluoride is actually a fluoride gas. But if it lands somewhere where maybe there are other metals, or where there is some calcium, it's going to bind with it, or whether there are deposits of magnesium, or I don't know how those things form. I honestly don't know that. But it will find a way. And of course, we are creating more natural fluorides. In 50 years' time, they're going to say it's really natural. But that's because all of our stuff, it's all going down the toilet. Yep, it's all going down the toilet, and it becomes part of the land and becomes part of the sea. Thank you very much.
Thank you. Thank you, Libby, very much.
Sorry,
Right.
I was a bit nervous.
Right. So the next speaker is Pat McNair from Fluoride Free Hamilton. And Pat, you have 15 minutes, including time for questions.
Hello, my name is Pat McNair. I'm a local business person. I do have a Bachelor of Social Science, which means that I'm not a biochemist, I'm not an expert on fluoride, exactly the same as all the council members here today, who have been given, in my mind, the unenviable task of deciding on this issue. I'm a member of Fluoride Free Hamilton, Fluoride Action Network New Zealand and Health Freedom New Zealand. I have children and grandchildren and I've lived in Hamilton for 45 years. Now before I go on to my presentation, I would just like to bring up one point that's occurred to me in the last 2 days, that a number of the presenters on both sides of the issue have brought up the fact that a lot of some European countries have fluoride in the salt, and I don't think that any of them have elaborated further on that, because it almost sounds as if it's mandatory, like fluoride is in the water in Hamilton. It's not mandatory, it's totally by choice. Only 4 countries in Europe have fluoridated salt: France, Germany, Sweden, and one other, I'm not sure what it is, but I could check. And apparently only 30% of the salt sold in the shops there have fluoride, so it's still very much free choice. And I think that also means that babies don't have to have it, because salt is not very often added to babies' food. So I'd like to go on to my presentation now. Now, due to time constraints, I'm going to leave the numerous and well-researched scientific and medical arguments to the highly qualified professionals who are presenting here at this tribunal on our behalf. But what I think I am qualified to discuss today are the ethical and legal aspects of the compulsory fluoridation of Hamilton's water supply and the consequent violation of the human rights of those who are forced to ingest this fluoridated water. As we have already been shown, current scientific and medical evidence clearly exposes the safety of water fluoridation as questionable and its effectiveness as unreliable. Having such potentially dangerous and as yet not fully measured side effects, it's therefore inappropriate to add fluoride to the water with the intent to medicate. As it stands right now, hydrofluorosilicic acid, or HFA, should immediately be removed from sale for the purposes of water fluoridation, in the same way that any other drug would be recalled if there was a similar onslaught of evidence of adverse effects. It appears that the rationale for fluoridating our water supply has always rested squarely on what can only be described as the legal fiction that fluoridated water does not constitute a medication. This is where it all starts to get a bit muddled, as fluoride is broadly touted as preventing oral disease, which is clearly a medical claim. The Waikato District Health Board claims water fluoridation provides an effective, practical and safe means for reducing and controlling the occurrence of tooth decay in communities. Clearly, this is seeking to improve oral health, so it is a medical claim. An analysis of the current situation in New Zealand can only conclude that an accurate and honest interpretation of the law would result in the conclusion that water fluoridation does indeed constitute medication, as it seeks to improve health by the addition of a chemical. Under the terms of the New Zealand Medicines Act 1981, if a product is presented to the public with a therapeutic claim or implication that it may have a beneficial effect on some medical condition, then that substance is legally classified as a medicine by definition. It is not enough to simply state that HFA is nothing but a nutrient or a supplement, both false claims incidentally, because if a medical claim is made on behalf of that substance, whatever the substance is, it is legally a medicine. Given this legal definition, it is difficult to see how anyone could deny that fluoridated water is a medicinal product. Thus, fluoridated water in New Zealand must be considered a medicine under MedSafe's own rules. In the USA, the FDA, an authority whose health rulings our own health authorities recognise and accept, defines fluoride as an untested medicine. Also, according to another of MedSafe's definitions, anyone involved in the administration of a medicine, in this case water fluoridation, to the public is a health care professional by definition, if a therapeutic claim has been made, and in this case, that fluoridation reduces and controls the occurrences of tooth decay. But council staff and water treatment workers have no medical qualifications or clinical experience, so they are breaking the law and essentially practising medicine without a licence. For anyone else, this would be a serious charge that could result in imprisonment or a fine. Under the Health Practitioners Competence Assurance Act 2003, only registered medical practitioners have the authority to prescribe a medicine or medicate anyone. It could be argued that the council is a supplier of a medicinal product, that is fluoridated water, and therefore it is acting beyond its powers under the Act. Unlike other chemicals added to the water supply to render it safe, fluoride is not part of required water treatment to ensure that it is potable. So instead of water being the object of the treatment, in this case it becomes the means by which fluoride is ingested by the consumer in order to reduce caries. So, does a water authority have the power to improve the health of consumers generally? At the moment, unless challenged, this may be legally correct in a muddled sort of way regarding fluoridation. But it certainly is ethically questionable. In Holland in 1973, the Dutch Supreme Court ruled that adding fluoride to drinking water went beyond the purpose of providing good drinking water. This judgment actually put an end to all water fluoridation in the Netherlands. It's only a matter of time that a case like this will be made in New Zealand, that water fluoridation goes beyond the powers conferred by New Zealand law. Another point is that all medicinal substances must be tested for safety and must comply with the regulatory standards applied by MedSafe. Now, in response to an official information request made by Imelda Hitchcock to the Waikato District Health Board in February of this year, where she was asking for safety reports showing that water fluoridation is safe, Dr. Felicity Dumble replied that the Waikato District Health Board did not hold nor had ever requested certificates of safety relating to water fluoridation. HFA has been tested in Europe and has almost universally been rejected for failing safety standards. Consequently, its use in water fluoridation has been banned in most EU countries. Can the Waikato District Health Board explain why it has never sought evidence of safety? I suggest the councillors ask them this question before this tribunal is finished. But the violation of medical ethics does not end here. Water fluoridation is indisputably a one-size-fits-all medical intervention that is being imposed on the whole population regardless of individual medical conditions. While it is impossible to know in advance exactly who will be affected by water fluoridation, it is a statistical certainty that some will develop fluorosis. Controlled dosage is a requirement of any pharmaceutical intervention, as is the knowledge of pre-existing conditions that would make this medication harmful. Consider, for example, the elderly who are toothless, the bottle-fed babies under 6 months, those with cardiovascular disease, renal disorders, vitamin C deficiencies, magnesium deficiencies, calcium deficiencies, etc. Now, water fluoridation also does not take into account any additional sources of fluoride, such as fluoridated mouthwash, fluoridated toothpaste, various food and drink products, prescription medicines, etc. And we can assume that those who are already receiving reasonable amounts of fluoride are more likely to be harmed. Also considering that under the Health Practitioners Competence Assurance Act 2003, council staff and water treatment workers have no right of access to the medical records of each citizen, or each patient as they should actually be called, how can they possibly take each patient's medical condition into account? Another ethical problem is that there is no control over how much anyone drinks, and no way that an individual can accurately measure their own daily dose. And unbelievably, this medical intervention has been set up without any monitoring system at all for adverse reactions to these unregulated dosages of fluoride medication. How can this possibly happen in New Zealand? And yet governing bodies in New Zealand like the Ministry of Health and the DHBs continue regardless to insist on their power, having convinced the public through emotive press releases that fluoridation of our water supplies is completely safe, necessary and effective. Seeing the Ministry of Health and the DHBs are determined to continue and even to expand compulsory water fluoridation, they are obviously hoping to be able to gather more data on which to base their justification of the practice. Therefore, it is clear that water fluoridation should in fact be reclassified as medical research, since the full health implications are still unclear and are increasingly being challenged. However, there are clear and extremely strict ethical procedures and safeguards in place aimed at protecting the public from improper medical research. For example, the Nuremberg Code established the basis for all modern medical research and treatment involving human subjects. The basic requirement is that even routine medical procedures, let alone research, must be done with the voluntary cooperation of the subjects, who must be fully informed of the risks and the benefits of the processes in which they are involved. Now, the issue of free choice is central to this ethical argument. Adding fluoride cannot be regarded as an optional intervention. Anyone who wishes to opt out would be at a serious financial and logistical disadvantage to the rest of the population. The obvious ethical requirement is that people must be required to opt into, not out of, medical interventions and exercise their free choice. Article 2 of the 1999 Council of Europe's Convention for the Protection of Human Rights and Dignity of Human Beings affirms the importance of the individual first and foremost with regard to biology and medicine, and therefore it affirms that water fluoridation is subject to the consent of the individual and not forced on the entire population. However, it is only for potentially life-threatening contagious diseases that the state's interests can override individuals' wishes. Clearly, tooth decay does not qualify as such a life-threatening disease. Finally, I have a few questions that I need to be addressed to, well, I think they need to be addressed to everyone's satisfaction before you as councillors make any decision. The first is, have you received informed consent from your patients as required by the Health and Disability Commissioner Act 1994? Have you informed your patients of all the possible side effects and complications? Have you informed your patients what action to take should they experience any of the reported side effects? Have you informed your patients of the steps to take if they inadvertently overdose? What are you doing to prevent people from drinking too much fluoridated water, or are you able to show that no matter how much they drink, they will be safe without any doubt? Have you budgeted for the cost of defending your action should a class action lawsuit be filed? In conclusion, I'd like to ask the Council to take heed of the precautionary principle that the Ruapehu District Council applied in their decision to move fluoride from the Tamaranui water supply in July 2011. You have a copy of their letter in front of you. For a definition of the precautionary principle, I looked up Wikipedia. If an action or policy has a suspected risk of causing harm to the public or to the environment in the absence of scientific consensus, then that action of the policy is harmful. The burden of proof that it is not harmful falls on those taking the action. So in conclusion, I ask you to take heed of the precautionary principle, and I say, if in doubt, leave it out.
Yes. Councillor Boss has a question, so we'll take one question.
Are you aware of anything else that our City Council may add to the water? And if you are aware, what is it, and is it a medicine?
Anything else that they do add to the water?
Yes. Is it only fluoride they add to our drinking
No,
water?
they add chlorine to the water.
Well, what is chlorine? Is that a medicine?
No, chlorine. Chlorine is used to disinfect the water, and it's a very important part of the process. That is not done to treat your body, that's done to disinfect the water. That's a water treatment chemical.
So,
Fluoride is not a water treatment chemical.
so what you're saying is that the treatment of our water apart from fluoride, that is not putting something in the water without somebody's consent?
It's not a medical issue because it's not a medicine. It's a different section. It's to do with treating the water. There are regulations that are involved with that, and they do comply with that.
Thank you.
Thank you very much, Pat, for your presentation. Okay, so we have a final speaker before lunch, and that's Libby Boyd, but she is coming to read, as I understand it, Libby, you're reading a letter on behalf of another submitter, is that right? Okay. Okay, all right.
This will be easier. Okay. This is Francine Jensen's submission to the fluoridation of water. In our modern diet, there is more than ample fluoride. Low concentrations have been shown to have detrimental effects on animal and human development. There is significant evidence that fluoride could have a deleterious impact on the nervous system. The dose cannot be controlled. Different amounts of water are consumed daily by people and infants. It's important to regulate. Terrestrial and aquatic ecosystems are at huge risk from the presence of fluoride. There is no way to remove fluoride from the water and plants and animals that ingest it. Fluoride is a poison, and it does not just disappear once it's been added to the water. The evidence that ingesting fluoride reduces the incidence of cavities has not been shown. Topical fluoride has been shown to have benefit. However, the risks of swallowing outweigh the benefits, especially for children. There is evidence of fluoridation slowing the eruption of the teeth in children, which could have the effect of reducing cavities. From bottle feeding, however, there is evidence that the delayed eruption is an indicator of damage incurred during tooth development. The link between fluoride ingestion and less cavities is very tenuous, and the public authorities should not be proactive in introducing medication into the water supply when the benefits are dubious. They need to be responsible and protect our water from any form of medication. It's absolutely unethical to force a medication onto a people without their consent. Francine Jensen. Thank you.
Very much for that.
Okay, thanks.
Okay, we're now going to be adjourned for lunch, and we're back here at 1:20.